In Blackpool, we had large numbers of patients attending the A&E department, either because they felt that their condition was quite urgent, or more commonly because they didn't really know where to access care quickly when they needed it, particularly out of hours or at weekends. And these patients could actually have been helped by other services in the community. So we have a walk-in centre, pharmacies, their own GP practice. There's lots of other ways for patients to access care that don't involve coming to an A&E department. And actually making sure that people got seen by the right person at the right time meant that the A&E department could deal solely with those very serious cases which did need an A&E response. We wanted to look at the numbers of people attending A&E and make sure that only those patients that really needed A&E ended up in A&E. We have 10 million visitors a year to Blackpool who come here either for the day or for short stays, who don't know where to access care when they need it. And a lot of those visitors are elderly with complex medical problems. We have a very deprived Indigenous population. We have high rates of transience. We have the worst male life expectancy in the country, so health needs are very, very high. But often our population, again, seek care in an unplanned way, didn't always know or access the best place for them to receive their care. And so people will come into A&E when they could have been more appropriately dealt with in community services. So what we wanted to do was make sure, again, that only patients who really needed to be in the accident and emergency department were seen there. We found that we've actually been really impressed. We've been quite excited by the results of the pilot. We're consistently diverting between about 17 and 20% of patients who attend A&E into primary care services. We use NHS Pathways to do that. That's a safe, well-established tool which goes through a clinical algorithm, asks patients a set of questions, and then at the end of the day the patient's either booked into the accident and emergency department and seen there, or they're diverted into our urgent care centre where there's a range of primary care professionals, doctors and nurses who can see the patients instead. If you want to use a triage process at a reception desk at A&E, which means that you're going to have admin staff, reception staff carrying out the triage process for you, then it's absolutely vital that that is a well-established, evidence-based triage process that clinicians have confidence in it is safe. So what we're actually doing, which is different from a lot of places, is that our reception staff are carrying out the clinical assessment process at the front desk. It's absolutely vital that the algorithm that's used is safe, because what we don't want is mistakes made and patients sent along to the wrong service. And we've got every confidence now that NHS Pathways is safe, that patients don't get sent out to primary care services if in fact what they need is A&E. And as I say, we are consistently seeing between 17 and 20% of patients who turn up at A&E who are being diverted into more appropriate community services. The trouble with A&E departments is that they're very, very busy. Staff are under a huge amount of pressure. There's a mixture of very, very sick people and people with much more minor complaints. And there's an obligation on the staff to make sure that everybody who comes into A&E is seen and treated within 4 hours. The more patients you have, the more difficult that is to do. In assessing a proportion of those patients within the primary care service, we mean that those patients are seen and dealt with much more quickly. It takes the pressure off the staff who are tending to the more seriously ill patients and enable those patients to be seen and treated much more quickly. Since we've been using NHS Pathways at the reception to A&E, we've found that the patients who are seen in A&E are much, much more clinically appropriate for that service. The patients who in the past might have been seen in A&E because that's where they attended are now being seen more appropriately in a primary care service or a community setting, and that A&E is able to concentrate more on the right patients for A&E. If people are looking at adopting NHS Pathways at A&E reception in the local area, I would suggest that there's a lot to be gained from this in ensuring that patients are seen in the most appropriate place. You do, however, have to understand that this was part of a much bigger unscheduled care project, so it's no good turning people away from A&E unless you've got somewhere appropriate that they can be seen within an appropriate timescale. All of the staff have to fully understand NHS Pathways and how it works. And clinicians, particularly in A&E but also in primary care, have to be fully engaged in the process. I think the big value of NHS Pathways at reception in A&E is that for those seriously ill patients who do need A&E, they are seen more quickly and the staff have more time to devote to those patients. I think for the patients who are uncertain as to where the most appropriate place for them to be treated is, NHS Pathways enables us to divert those patients into the most appropriate service rather than leaving them sitting for long periods of time waiting in A&E with a problem that shouldn't really be in A&E in the first place. Finally, I'd like to add that we've seen huge benefits here in Blackpool of using a NHS Pathways as a triage tool at A&E reception. There are huge cost benefits around patients being seen more appropriately in primary and community services rather than seen in A&E. There are huge clinical benefits in that A&E is able to concentrate on those patients who really need A&E services, and there's benefits to patients, if only around the timeliness of the interventions we're able to offer them.